Hi, it's good to see you again. I was going over your monthly labs and it looks like your hemoglobin is a little low. Let's go ahead and talk about what that actually means. Let's start with the basics. Hemoglobin, or HGB, is a protein inside your red blood cells. Its job is to carry oxygen from your lungs to the rest of your body. So when your hemoglobin is low, your body isn't getting the oxygen it needs. That's why people with low hemoglobin often feel tired, weak, short of breath, dizzy, or just completely drained. Think of your red blood cells as delivery vehicles. Inside each of those vehicles is hemoglobin. Hemoglobin is like the delivery truck that carries oxygen, which is the package your body needs, and iron is the fuel that helps those trucks run. But we'll discuss iron in a different video. So, if you don't have enough red blood cells, you don't have enough delivery vehicles. If you don't have enough hemoglobin, you don't have enough trucks. And if you don't have enough iron, those trucks don't have the fuel to do their job. So, why is anemia so common in people with kidney disease? Now, remember in the intro to CKD video I posted when I showed you the different functions of the kidneys? We're going to be referring back to that scene a lot because your kidneys do more than just filter your blood. One of those important functions is hormone production. And this is where anemia comes into play. Healthy kidneys make a hormone called erythropoietin, or EPO. EPO's job is to send a signal to your bone marrow to make red blood cells. But when the kidneys are damaged, they don't make enough of that hormone. So your body doesn't get the message to make more red blood cells. And over time, your hemoglobin drops. That's how anemia develops in chronic kidney disease. When your hemoglobin is low, you may notice symptoms like fatigue, feeling cold, weakness, shortness of breath, or difficulty keeping up with daily activities. Some people feel it right away, and others don't notice symptoms until the hemoglobin drops lower. This is why we don't just look at how you feel, we also watch the numbers closely. Now, here's something important that surprises a lot of people. Higher is not always better when it comes to hemoglobin. If hemoglobin goes too high, the blood can become thicker. That can increase the risk of blood clots, stroke, and even problems with your dialysis access. So, our goal isn't to make your hemoglobin as high as possible. Our goal is to keep it in a safe, balanced range. To treat anemia and kidney disease, we usually use two main types of treatments. The first is medications called ESAs, or erythropoiesis stimulating agents. You may recognize names like Epogen, Procrit, Aranesp, or Mircera. These medications act like the EPO your kidneys are not making anymore. They tell your body to make more red blood cells. The second part of treatment is iron. Iron is needed to actually build hemoglobin. If your iron is low, these ESA medications will not work very well. That's why many dialysis patients receive IV iron along with their anemia medication. And I promise we will dive more into iron during our Learn Your Labs series. If your hemoglobin comes back low, most clinics won't panic over one number. We look at trends over time. Is this hemoglobin value a random number when all of your trends have been normal? Or have you been seeing a gradual decline over time? In both cases, a nursing assessment will be required. Your nurse will assess to see how you're feeling and check for signs and symptoms of bleeding. We may ask questions like, are you feeling more tired than usual? Are you feeling more short of breath? Have you noticed any blood in your poop? Or have you had any dark, tarry looking bowel movements? These questions help us to figure out if your hemoglobin dropped because of blood loss or another reason. We will also check your iron levels. to see if those red blood cells are running out of gas. We may adjust your ESA dose and give you IV iron as needed, per protocol or provider orders. In more severe situations, a blood transfusion may be considered, but that's usually the last resort. The key thing to understand is that anemia management is a process, not a one-time fix. Now, there are situations where your hemoglobin will result in the critical range for your clinic, and then you're sent to the ER, and your hemoglobin is just high enough to where it does not require a blood transfusion. This is actually very common. Hemoglobin can change based on fluid status. It can change depending on if your labs were drawn before or after dialysis. So it would make sense that the hemoglobin drawn at the ER would be slightly higher because your hemoglobin was drawn after dialysis removed that extra fluid. Different labs use different machines, and points of care testing at dialysis clinics can give slightly different results than hospital lab testing. A small difference does not mean that something is wrong with the process. It usually just means that your labs were drawn under different conditions. The most important thing to remember is, if there is any doubt and your nurse or doctor is advising you to get your hemoglobin checked, it's best to go ahead and get it done. This gives you peace of mind and gives your healthcare team a more accurate picture of what's going on. Then we can either continue with your current plan of care or make adjustments as needed. You may also notice that your hemoglobin target ranges are slightly different depending on whether you are pre-dialysis or on in-center hemodialysis or on peritoneal dialysis. These ranges are usually still close, and they are set with your safety in mind. We're not chasing perfect numbers. We're aiming for balance. Understanding your labs help you understand your body. And the more you understand your labs, the more confident you can be in your care. This is your health, and these numbers tell a story. If this was helpful, follow along for the rest of Learn Your Lab series.